Thanks, Dr. Lowe. Really appreciate it. Thank you, and the committee, first and foremost, for all of the work that you guys are doing for us. In my position in leadership at the FDA, I see all of the many activities we're doing in the area of opioids and the opioids crisis. I consider this one of the more important things that we've got going on. Really critical for us to move forward, not just today, but going forward, into the future as we try to respond to this crisis, which continues to unfold. Let me figure out where my forward is. Sorry, I'm going to have to figure out. There we go. What did I just do? Why don't you go to the start and I'll try pushing a button. All right, so today what I'd like to do is three things. First, I'm going to talk about, in a very general sense, about the background of the epidemic and the focus that we have on prescription opioid abuse. That is the tasking for the group, is the focus on that particular aspect of this crisis. Then I'd like to transition into some of the data that have led us to ask you all to do the work that you're doing, and then end with a discussion of the statement of work and some of the things that we hope that you're going to be able to help us with. So, prescription opioid abuse is the thing that you're being asked to focus on. Just to remind, prescription opioid abuse is an ongoing issue, continues to be a problem. Large numbers of individuals are challenged by opioid abuse that have a source in prescription opioids, and we're looking to do something about that. The consequences are also terrible. We all know someone that has been touched by this crisis. If you don't think you do, you haven't asked enough people. It is just simply everywhere, and we have to find some way to do something, given the FDA in our remit, focusing in on prescription opioid abuse first and foremost. This is ongoing. This crisis continues despite a falling number of prescriptions for opioids entering the market in the U.S. And these are data that I just got last week from my epidemiologists. You can see that the numbers of prescriptions continue to decline. You can also see that the prescriptions continue to be dominated by the immediate release opioids. So we continue to see the IR Oxycontins and hydromorphones be the largest fraction, over 90% of the prescriptions that are put onto the market every year. So, as a consequence of this, the FDA understands the critical need to do something about this. I won't read through this quotation. It comes from my commissioner very shortly after he started his tenure at the FDA. He met with me and Dr. Woodcock within a day of being confirmed, and the first and only thing we talked about was opioids. As you can imagine, there are other things going on in the Center for Drugs. That was the one thing he wanted to focus on, continues to be among the highest priorities that we have as an agency, given its seriousness, given the need for the agency to do everything that we can. So, the priorities as a consequence fall into four buckets, and the FDA has used these four priorities to guide the work that we do, to guide the decisions that we're making about where our resources are going and who's going to be working on them. And the goal then is to make certain that everything we do ties back to these four activities, these four pillars, if you will, ultimately resulting in an improved response to the opioids crisis. I won't walk through all of the many activities that are underneath those four pillars. I'm happy to answer any questions that you have about any of them, and if we have time. Suffice to say that there are literally dozens of activities. We have staffs that are devoted to tracking the activities we do around opioids. Each and every one of these pillars have important activities across the agency that we're doing every day to try to address the opioids crisis. I've put in red where the discussion for today is focused and where the statement of work falls. And you can see decreasing exposure and prevent new addiction as the first pillar for Dr. Gottlieb's priorities for our response to the opioids crisis. It makes sense. Think of it as primary prevention. Think of it as preventing new addiction, new exposure, new potential risk. Anything that we can do to help that is going to help the downstream consequences, including, the transitions to illicit substances and other abuses of opioids. So it's the first and most important pillar that we have, the thing that we're focusing our attention on. And for today, we're focusing on appropriate packaging, appropriate dosing, duration, and labeling. This also dovetails with recent legislation that was passed late in the year last year called the Support Act. I'm going to have to look up and read what that stands for. Substance use disorder prevention that promotes opioid recovery and treatment support. I won't go through all of the things that the Support Act gives the authority, the FDA new authorities to require. I do want to highlight the boldened phrase, which reflects a new authority that the FDA has to reduce exposure to opioids as a way of lowering the rate of new addictions. This is through a variety of means, including packaging and labeling and other things that I won't get into. Suffice to say, it reflects the importance that Congress places on this issue. Also reflects the acknowledgement that there are things that the agency can do to help in this crisis. So, where do we go given that landscape, given the importance of this for us to do something? It starts with a look at the data. And I'm going to talk through just very briefly some of the things that we've seen recently. First, talking about the excess numbers of opioids that exist to reflect the fact that we're putting more opioids into the world than we need to when we're prescribing and dispensing them. And talk a little bit about the potential consequences of those excess opioids. So, what we know from the data is that opioid use varies widely. The numbers of opioids that are prescribed for a given therapeutic use vary widely between individuals. They also vary widely between therapeutic conditions. So, no surprise, a tooth extraction gets different numbers of opioids than an abdominal surgery, for instance. But we also see tremendous heterogeneity between individuals, between the numbers of pills that prescribers are giving. The third piece we know is the consequences are large numbers of leftover tablets. And I've highlighted the far right-hand column, the red, to emphasize that. So as we look across studies, we see large numbers of leftover tablets for individuals that are going to go into their medicine cabinets, that if they're not returned are going to sit around and be available for diversion and misuse and abuse. This is the target. This is the target of the work that we're asking you to help us with, is these excess opioids and what we can do as an agency to try to reduce them, to try to right-size these prescriptions, rational prescribing, if you will. We've seen the same thing in other settings. This happens to be in post-surgical populations. Here again, 50% of patients report excess opioids when they're done with the recovery from their procedure. And those excess opioids, we know, sit in medicine cabinets for long periods of time. The human nature is to hold on to them just in case. And I'm sure if we asked around the room, many of us would have opioids potentially in their medicine cabinets that they're not returned. That's not in and of itself a problem for the majority of medicines, but we know that for opioids, having them available in the medicine cabinet, having them available for diversion, theft, misuse, use by family members that they're not prescribed for, has important negative health consequences. So that available supply of opioids sitting in that medicine cabinet or in an unlocked, unsecured space can lead to third-party access, which in turn leads to misuse and related outcomes and accidental exposures that can ultimately start someone down the road towards opioid use disorder and the tragic consequences that we're all familiar with. So intervening in this trajectory, intervening to right-size prescriptions and reduce the numbers of excess opioids that are available is an important prevention tool, it seems to us, to intervene and prevent long-term development of opioid use disorder. So opioids, as a consequence, the FDA is working in a number of areas to support rational opioid prescribing. First, we continue to educate prescribers. We continue to work with them through our continuing medical education that we require manufacturers to provide to them. We're also exploring packaging solutions. I won't talk in detail about this, but we believe that there are ways to create new packaging configurations that will make it attractive for prescribers under appropriate circumstances to prescribe fewer opioids than they are at present, leading ultimately to fewer excess opioids being placed into the environment and available for diversion. We also think that those packaging solutions could allow for tracking and a better understanding of how the opioids are being used. We think that has potential value for prescribers and patients as they talk about the continued use of opioids. For today, though, the third piece is the piece that is the focus of your discussions today, supporting the development of objective, evidence-based guidelines for the use of opioids in acute pain. The prescriber has a critical role here, and to the extent that we can give the prescribers high-value, high evidence-based guidance on the numbers of opioids that are needed for particular therapeutic conditions, we believe those prescribers will respond by right-sizing those prescriptions, reducing the total numbers of excess opioids, and obviously a public health benefit. So, FDA is taking steps to encourage medical professionals to develop evidence-based guidelines based on appropriate prescribing of opioids for different medical indications. We're doing this to help advance the development of new evidence-based prescribing recommendations, to go beyond the current guidelines, which are in many cases relying on expert opinion, on experience. It's critical. These are valuable, highly valuable guidelines. In this case, where possible, it's going to be important to go beyond that, to find a way to develop better data, to understand in an evidence-based way the real need for opioids in these therapeutic conditions. So, we have obviously asked you all to help us with this, and the statement of work that you had reflects this interest, reflects our critical need for your help. This is something that's challenging for us, and we're looking forward to all the work that you're going to be able to give us. So, the tasking for the committee, you have outside, I've summarized it here into three large buckets. The first is to identify the available evidence for prescribers, and to provide a framework, an evidence framework, if you will, for how we should consider the quality of the data as you identify it or as it is developed, to support a more appropriate prescribing of opioids while ensuring that patients with pain are adequately treated. This will not be a success if we reduce opioids inappropriately to the level that patients are no longer appropriately receiving treatment for their pain management. So pain management is essential. Doing that requires good evidence, partnership with the prescribers, careful, thoughtful approaches to pain management. And then, where necessary, supporting the development of new evidence for rigorous evidence-based guidelines to inform those prescribers, help them make the best possible decisions they can about the numbers of opioids that are needed to manage a given pain condition. First and foremost, then, framework development. Developing a framework for evaluating the evidence-based underpinning clinical treatment guidelines for opioid prescribing for acute pain. Here there are other guidelines that exist. There are other frameworks that exist, and we're looking forward to having you review those. It may be that those are sufficient. We don't have a view on that. This is something that many people have talked. Dr. Chow is on the group, and we're looking forward to his help with that, for instance. This is the beginning, is understanding how you're going to look at the data, understand them, and make recommendations about them. Then we want you to assess the current state of the data on prescribing. As I indicated, we know that there is an inventory of surgical and medical conditions associated with acute pain. The data available on the numbers, on the use of opioids in those conditions vary. And it's important that you have an opportunity to look at that, identify the data that are high quality, identify the data that are not high quality, where we may need potentially to have additional work. We also need you to prioritize those conditions. There are a large number of pain conditions that are potentially amenable to short-term opioid use. Some of them are very large and very impactful. Others potentially less important for us to devote immediate attention to. We need your help to separate those conditions out. The data that you're going to be looking at comes from a variety of places, and many of you are experts in various aspects of those data, and we're really delighted that you're on the committee. We are agnostic to where the data come from. We are most critical about the quality of the data. So you ask about real-world evidence, or you ask about whatever other sources of data. I'm going to say we're open to those sources of data, but I'm going to it's going to be very important that the data that you use there are of high quality and they're actually applicable to the issues at hand. This is an example of the kinds of recommendations that we've made in the past in a related area. This is a pharmacoepidemiologic safety studies. And in 2013, we put out a guidance that made recommendations for how to identify high-quality studies in that particular area. I'm using it as an example. There are other ways to identify what high-quality data look like, but this is the kind of thing that we're going to be looking for. Where the data come from are for you guys to help us with. The quality of the data is absolutely paramount. And then the next part of the statement of work was the research agenda. As I'd said before, we need you to provide us with a prioritized research agenda. Identify the work that's essential to be done, some ideas, if you have them, about the ways that we can accomplish those. And I believe the statement of work asked for a minimum of 5 conditions for indications that are abuse-prone or commonly prescribed. Ask you to look back at that and make sure that you give us the help that we need there, again, in a prioritized way so that we can choose the things to do early and then the things that could potentially wait some time. And then I'm looking forward to everything that you're going to tell us. We will take your recommendations very seriously. As you know, we have used the National Academies in a variety of ways over many years. Some of the most important documents that have been provided to us from outside groups, I would say, come from the National Academies in the past. And so this is a particularly critical one for us. Looking forward to the recommendations, looking forward to the ideas about where you believe we should be going next to identify high-quality data and make those high-quality data available in a sort of systematic way for use by prescribers. Our goal is to improve the science supporting the clinical practice guidelines for acute pain. We need that. We need to step beyond the experiential data that have guided us in important ways up to now, creating a framework for the evidence generation, inventorying the available data, and making recommendations to us about prioritized future work. With that framework, FDA can then take those data, ideally include some of those in labeling, and find other ways to make them available to prescribers through the other work that I mentioned before. Be evidence-driven, and if the evidence doesn't exist, work to get it. I think that neatly summarizes the help that we need from you today. I'm very much looking forward to all of the work that you're doing, and I'm happy to answer any questions I can. Thank you very much.
Doug, if I could, this is an opportunity for the panel to ask Dr. Throckmorton a question. If I could ask you to say a little bit more about an issue concerning the statement of tests that's come up in our internal planning for this workshop today. And that's what do you really mean by opioid prescribing? Is it primarily outpatient prescriptions that doctors write prescriptions for, that pharmacists fill, and are inpatient techniques, interventions to control pain included primarily because they can affect what happens in the outpatient prescribing center? Do you want, but you don't really want us to talk about inpatient management per se, or do you?
So our focus is on outpatient, and it's primarily for two reasons. First, just simply impact. Just the sheer numbers of opioids that are available for diversion, misuse, and abuse come from the outpatient setting. So those pills in the medicine cabinets, by and large, are coming from outpatient prescribing. Yes, there is transitional prescribing that occurs when you go home. That is, I'm including that in that bucket. But The opioids we're worried about, that we're really focusing on here, are the ones that are available in the home, available in the outside world, and available for diversion. And the second reason is because we acknowledge that there are other controls over hospital use opioids, other mechanisms, if you will, that are inventorying, controlling, overseeing the use of those opioids that really make it a fundamentally different use of them. And so our goal is going where the money is, which is the high volume outpatient prescribing.
Great, thanks. Any questions from the committee for Dr. Throckmorton and the FDA? Dr. Delgado?
Hi, Kit Delgado, University of Pennsylvania. One question I have is, to what extent is the FDA interested on the evidence for non-opioid alternatives for these common conditions? Because it tends to be for a lot of conditions, opioids are used when there's not great non-opioid alternatives to control the pain. So I'm trying to figure out how to include that in this analysis.
Yeah, great question. So we know opioids fit inside a much larger pain management world. And so, yes, without any question, to the extent that the data you uncover identify when opioids should be considered, I think that's important for us to understand. The focus of this is on right-sizing opioid prescribing when that's appropriate. So your question covers the when that's appropriate part of that, isn't it? I think for us, we believe the challenge of the data on how many opioids to prescribe when they're the right thing to prescribe is large enough so that that's an important focus. Asking you to step to that next layer and look across the entire spectrum of management of pain and identify when an opioid would be prescribed and useful, that just simply may be larger than the scope of the committee's able to undergo. But the when it's appropriate is important for us too.
Your eloquence and clarity have stunned us into silence.
Or they need coffee, one of the two, yes.
Well, thank you, and thank you for the extra 16 minutes you've given us on the schedule.
Thank you very much, guys. We really do appreciate it.